Fetal tachycardia is defined as a baseline fetal heart rate greater than 160 beats per minute. Mild fetal tachycardia is between 160 and 180 beats per minute. Severe fetal tachycardia is greater than 180 beats per minute. A fetal heart rate above 200 beats per minute is usually due to a fetal arrhythmia or congenital anomaly, not hypoxia. Persistent fetal tachycardia above 180 beats per minute, along with maternal fever, often indicates intrauterine infection such as chorioamnionitis. Persistent fetal tachycardia may signal fetal stress, but is not always a sign of severe fetal compromise unless variability is also decreased. Fetal bradycardia is defined as a baseline fetal heart rate less than 120 beats per minute. A fetal heart rate of 100 to 120 beats per minute with normal variability is typically benign. Fetal bradycardia is common in post-term pregnancies and in fetuses with occiput posterior or transverse positions. Bradycardia below 100 beats per minute may be due to congenital heart block or myocardial conduction abnormalities. Fetal bradycardia may occur due to maternal autoimmune antibodies such as anti-Ro or anti-La transferred transplacentally. Fetal bradycardia with preserved variability is considered intermediate and not immediately concerning. Fetal bradycardia at or below 80 beats per minute, lasting more than 3 minutes, is a serious sign of fetal hypoxia. Causes of fetal tachycardia include fetal hypoxia, maternal fever, maternal hyperthyroidism, maternal or fetal anemia, and medications such as atropine, hydroxyzine, ritodrine, and terbutaline. Fetal tachycardia may also result from intrauterine infection or prematurity. Causes of fetal bradycardia include prolonged umbilical cord compression, umbilical cord prolapse, excessively strong or tetanic uterine contractions, paracervical block, epidural or spinal anesthesia, maternal seizures, rapid descent of the fetus in the birth canal, and vigorous vaginal examination. A saltatory pattern is characterized by baseline fetal heart rate variability greater than 25 beats per minute. Saltatory pattern is often caused by acute umbilical cord compression or sudden hypoxia. When saltatory pattern is seen along with late decelerations, it may indicate acidosis. Saltatory pattern is considered an intermediate finding and does not necessarily require immediate delivery. Early decelerations are gradual decreases in fetal heart rate caused by fetal head compression during uterine contractions. Early decelerations mirror the contraction pattern and are generally benign. Late decelerations begin at or after the peak of the contraction and return to baseline after the contraction ends. Late decelerations are smooth and symmetrical and may indicate utero-placental insufficiency. Persistent late decelerations are concerning and suggest possible fetal acidosis. Evaluation with fetal scalp pH or other assessment is needed if late decelerations continue. Variable decelerations are abrupt decreases in fetal heart rate and vary in timing, shape, and duration. Variable decelerations are commonly caused by umbilical cord compression. They may occur with or without contractions and are often seen during labor. Isolated variable decelerations are usually benign, but repetitive or severe patterns may be concerning. Features that suggest variable decelerations may indicate fetal hypoxia include increased depth and duration of deceleration, delayed recovery, a blunted or absent post-deceleration acceleration, accompanying fetal tachycardia, saltatory variability, decreased baseline variability, and delayed return to baseline heart rate. A sinusoidal fetal heart rate pattern is a smooth, wave-like pattern occurring 2 to 5 cycles per minute with an amplitude of 5 to 15 beats per minute. Sinusoidal pattern is rare but ominous and indicates severe fetal anemia or hypoxia. It is often associated with Rh incompatibility and fetal red blood cell destruction. Sinusoidal pattern is considered an emergency and requires immediate delivery.